स्टार्ट होने वाली है मीटिंग।
डॉक्टर मीरा अग्निहोत्री मैम को भी बुलाना होगा ना ब्लेसिंग्स के लिए। डॉक्टर मीरा अग्निहोत्री मैम लॉगिन है।
मीरा अग्निहोत्री मैम है लॉगिन में?
हाँ लॉगिन है,
तो बुला लेंगे मैडम को।
हाँ
सविता
डॉक्टर मीरा अग्निहोत्री मैम लॉगिन है, और हमारी प्रेसिडेंट डॉक्टर उषा को इनका भी कुछ बोलेंगे फिर आप जस्ट।
तो डॉक्टर मीरा अग्निहोत्री की तो हमारे पास सीवी नहीं है।
नहीं है, मैंने भेजी हुई है सविता जी को, आपको भेज देती हूँ।
आप भेज दो फिर सीवी भेजो कि फिर एक्चुअली किसे किसे इनवाइट करना है पता तो रहे ना।
मैंने भेजा हुआ है, डॉक्टर सविता से बात हुई है।
तो सविता को पता होगा, फिर सविता कर देगी। यदि सविता को पता है, उसने मुझे नहीं
मैं
बताया।
आपको भेज रही हूँ।
सविता हो गया?
मैम मिल गया आपको?
कंचन जी अभी तो नहीं मिला एक्चुअली, आज इसकी भी प्रॉब्लम हो रही है, लेकिन हाँ मोबाइल डेटा तो ऑन है। हाँ मिल गया, अभी अभी आया है आपका, मिल गया। सविता गायब हो गई है।
क्या करें आरती जी, फिर स्टार्ट करें क्या?
मेरे हिसाब से वो
क्या हुआ?
मैं ये कह रही हूँ डॉक्टर मीरा मैम ने भी तो ज्वाइन किया हुआ है ना, डॉक्टर मीरा
हाँ तो डॉक्टर मीरा मैम को इंट्रोड्यूस करा के उनसे ब्लेसिंग्स ले लेंगे, और फिर डॉक्टर उषा गोइनका की भी मैंने आपको भेजी है।
ठीक है कर लो, फिर स्टार्ट कर लो, है ना, टाइम हो गया।
करो स्टार्ट, क्योंकि फिर वो उनका भी है ना डॉक्टर संध्या अग्रवाल। डॉक्टर उषा को आप इंट्रोड्यूस करा दीजिएगा कंचन जी।
हाँ
ठीक है,
आप डॉक्टर मैडम को करवा दो पहले
मैडम संध्या को कराना है।
मैडम मीरा अग्निहोत्री मैडम है ना, उनको करवा दो फर्स्ट। मैडम ने करवाया ना ज्वाइन, शायद मैडम ने ज्वाइन नहीं किया ना अभी, हमारी मैडम ने।
मुझे नहीं पता, डॉक्टर मीरा अग्निहोत्री को मैं करा देती हूँ, है ना। और उसका नाम
तो बोले बुलाएं।
हाँ
नहीं तो तुम पहले शुरू तो करोगी, फॉर्मल तो शुरू करोगी सविता।
हाँ टुडे वी आर गोइंग, मैं आपको बुला लेती हूँ ना, फिर आप थोड़ा सा इंट्रो वो कर दो।
हेलो डॉक्टर सविता। हेलो डॉक्टर कंचन।
हेलो मैडम, गुड आफ्टरनून।
हेलो उषा जी।
हाँ उषा जी, देखो
आपकी शक्ल अच्छा ये आप देखिए। हाँ ठीक है।
अच्छा वी शुड स्टार्ट नाउ, आई थिंक सो ना।
इट्स ऑलरेडी 4 बज चुके हैं, हम शुरू कर सकते हैं।
हाँ चलिए करिए।
तो टुडे वी आर गोइंग टू have one very important webinar on REC, that is respectful abortion care. It is an initiative of FOXY and WHO, and today 2 societies, not only 2, 3 societies are together to give the training to their members about what amendment has been done and what is the respectful abortion care. 4 modules are there for that purpose, and that will be taken by the master trainers. Now I invite our president, Dr. Aarti Gupta, to give the welcome address to all.
Thank you, Savita. Very warm welcome to all my seniors and to all the delegates or my companions who have joined this RAC, respectful abortion care. And we are going to talk about what is this respectful abortion care all about. The most important thing which I want to tell you is this: there is the amendment in the law of the abortion. That is one part of today's training. The most important part of today's training is this: we have to focus how we have to counsel the patient, how we have to tell the patient she can go for abortions without having any feeling of humiliation. Most of the time in our chamber, when the patient is coming for the MTP, then we are not giving a very good response to that couple. Usually we used to say, why you have not taken any precautions before, why you are coming at 12 weeks of the duration or 16 weeks of the duration. There are so many reasons which a couple may have for that she is unable to come to us. So now we have to understand that we have to give a very respectful, dignified counseling to each and every couple, so that the couple can have a respect and dignity to go through her process of abortion. This is very important. I am not going in detail. I am again welcoming you all. And now I will like to invite Dr.
Usha Goenka.
Dr. Usha Goenka ma'am for the blessings. And now I will ask to Dr. Kanchan to introduce Dr. Usha Goenka and call her for the blessings.
Good evening, one and all. I am Dr. Kanchan Sharma, Secretary of Kanpur branch. This is a matter of great pleasure that we, Kanpur Agra Society, are jointly organizing RAC training. For that, just to welcome, we have a very senior, our patron, ma'am, Dr. Meera Agnihotri ma'am, just to bless us. And first of all, I will invite our President Madam, Dr. Usha Goenka, to say a few words and introduce our inspiration, Dr. Meera Agnihotri, she will give us a few words of blessings. First of all, I invite and hand over mic to Dr. Usha Goenka.
Thank you, Kanchan. Thank you for very kind words. Good evening, Dr. Aarti, Dr. Savita. It is my great pleasure to be associated with Agra Society. We are very lucky to have such a visionary and empathetic president, Dr. Shanta Kumari. She is very, very far-sighted person. Respectful abortion care is the right of every woman and every young lady to have respectful abortion care. पहले the patient लोग पास आता था, when you उससे हम लोग interrogation करते थे. How did you conceive? Why didn't you? As Dr. Aarti was saying, now we should give due respect to every girl, whether she's an adolescent or she's a married lady, she's unmarried, doesn't matter. Everybody has got the right to have respect to abortion care. And our society and all the societies of Foxy, they are very actively participating in this. I congratulate Dr. Kanchan Sharma, Dr. Aarti Gupta, and Dr. Savita Tyagi to organize this webinar on RAC. Thank you so much. Wish you all the best for this program.
Thank you, ma'am.
Introduce Dr. Meera Agnihotri, ma'am.
वो भेजो मैम का
CV आरती जी हम
Yes, I can read the CV of Dr. Meera Agnihotri ma'am. Now I will like to invite Dr. Meera Agnihotri ma'am. She is professor and head of the Obstetrics and Gynae, GSVM Medical College, Kanpur, Chairman Ethics and Research State Medical Call, and President WWW Foundation, Advisor Women Health Cell Ministry of the Health Government of India, Shaphat 1000 for National Health Program launched on 24 January 2021. And she has so many things in her profile, and represented India as Foxy National Chairperson AIDS 9th FIGO at Montreal, Canada, and she has national contribution to organizing secretary of AICOG, founder chairperson of FOXY, elected governing council, executive member ICOG twice, and ma'am, there are so many. It's a very
Thank you,
long.
Aarti. Thank you very much.
You are our inspiration, and
Miss.
thank you. And I see Ajay ji also, just a welcome. And Dr. Meera Nyuti ma'am, please give us blessings.
At the outset, it's a great honor to be a part of this very, very important meeting, which is being planned by the head office for its members. Earlier we were talking about respectful maternity care. Now we have localized it to the respectful. Every woman, every girl has got a right to have abortion facilities with dignity and desire. So respectful maternity care has got very many wings. And one out of it is this one. Why? Because there are revolutionary changes in the MTP committee, in the MTP procedure, and in the legal cell of the medical termination of the pregnancy. Earlier, we were not allowed to do medical termination of pregnancy. There was no word like medical termination of pregnancy till 1972. Dr. Sandhya, good evening.
Madam Sandhya is there.
Yes.
Yeah, she's
Sandhya,
there.
good evening. Sandhya is my batchmate, probably you don't know.
Okay.
And a friend of mine. Anyhow, so earlier when we were teachers as a lecturer or as a demonstrator, termination of pregnancy was supposed to be a criminal abortion. So we were taught as criminal abortion in those days. Then there was a legalization 1972 onwards. Then there was a termination of pregnancy with 2 doctors, 3 doctors, and it kept on changing, depending upon the circumstances, our need, and very many things. Now ministry has decided that there are certain important legal changes in the termination of the pregnancy as regards its duration. And we must all be fully aware about this journey of termination of pregnancy right from criminal abortion before 1972 up to 2022, so that we may know what changes have occurred, why they have occurred, and if the changes have occurred, why should we do it in the same way we used to do earlier. So respectful care is very, very important as regards the abortion, and certain laws which are changed, they will be discussed in detail. I am really honored and I congratulate Shanta and whole organizing committee at the head office for making it a part. When we used to meet before she became president, there are a few things which we used to discuss, and that was about Dhira, that is violence against women. She used to tell Meera ji, we will be working, because I am also very much interested in WW Foundation Women Empowerment. And the second thing is the termination of pregnancy. Probably all of you know that Dr. D.K. Tank has very vigorously worked on these issues earlier also. And now ministry has given us this opportunity. So we must be fully aware with the latest legal application, with the latest methods of termination of pregnancy, and how should we behave with the couple when either the patient is coming as an unmarried patient or a married patient with the circumstances with which she is there. So Kanchan, Usha, Aarti, and really honored to have Sandhya by my side, and Dr. Ajay, I can see, Savita, I can see, Kanchan, thank you very much for making me a part of this visionary meeting. I believe it will go back with a very good back home messages with the existing knowledge for each and every one. And it is the time that we must tailor our knowledge according to the circumstances which are prevailing, according to the present laws, and according to the legal application. Our behavior to the patient must also be changed, whether we are sitting with a 200 patients OPD or we are dealing with a 1 patient OPD. So thank you very much, Aarti, for making me a part of it. Thank you, Kanchan. Thank you, Usha. And again, sharing the dais with Sandhya is a real pleasure for me.
Thank you, ma'am, for your exemplary vision and blessings to us. It will definitely make our program a great success. Now I hand over to Dr. Savita.
Now I invite our respectable patron, Sandhya Agrawal ma'am. She is a past ex-professor, SN Medical College. She is mentor, teacher, and teachers of the teachers. And she's also always there to support us in every field. Ma'am, please shower your blessings for this program also. Say a few words.
Please unmute, ma'am.
Unmute, ma'am.
Please tolerate my hoarse voice because I am having a very bad throat. I would like to extend thanks to all of you to invite me and to make me a part of this such an important topic. Before it was legalized, we were facing the women in a real, very, very bad shape, who are termination of pregnancy by the courts, which is beyond your imagination. But now the laws are being changed, and we should give respect. It is the right of the female to carry a pregnancy or not to carry a pregnancy. So we have to look, we have to give the right to a female and to terminate a pregnancy very legally, following all the rules. So none of us can land up in consumer protection.
Thank you, ma'am, for your kind words. We always need your blessings whenever we have any program like that. Now, I hand over it to the Dr. Aarti to start the first session.
Thank you, Savita. Thank you so much. And in today's program, which is a most important program regarding the medical termination of the pregnancy, in which we are going to know about what are the changes in this amendment of medical termination of the pregnancy. To start this, we should know few things about this. The medical termination of pregnancy is launched in March, but the final application of the law was done in 25th September 1921. Now we should understand one thing, ki India is supposed to be a very progressive country regarding the abortions. India is the first country who is providing such an respectful abortion care to our patients. And this is the first company who has done the limitations of the abortions till 24 weeks of the pregnancy. In this respect, our India is going to be very progressive and one of those countries which the other countries can look at India for the same. So in this medical termination of the pregnancy, if we will move to the further, now the objective of the module is we will take a closer look at what are the new laws and what are the changes in the rules. Unsafe abortions in India lead to mortality and mortality, and most of the girls and women are unable to fully participate in their life. About 8% of the maternal deaths per year is due to the abortions. This is the third leading cause of maternal mortality rate. And the second thing is this, nearly 2 out of 3 of the abortions performed are deemed unsafe. This is very important. We should know about it. We are having such a huge number of unsafe abortions. And this is one of the law which will help us so that we can stop these illegal abortions and we can contribute to the health of our females. Nearly half of the pregnancy related deaths are in women and girls under the 25 years of the age. So can you imagine ki more than half of the maternal mortality rate is of the females who are less than 24 years. So we can understand ki what is the unsafe and how much unsafe is these abortions and the other causes of the pregnancy-related deaths, in which one of the most important cause is the low-age pregnancies at the age of the 18 years, 17 years, and 19 years. That is also a cause, but abortion is one of the leading cause for the maternal mortality rate. So when is abortion considered safe? The abortion is considered safe when it is provided by the appropriate method and by trained person. When trained person are giving the abortion with the appropriate method, then that will lead to the safe abortion. Now, if we will come on the what are the silent features of the amendment of 2021, so we will come to know that initially we all know the requirement. What is our requirement? So we know the MTP up to the 12 weeks can be given by the one RMP, and pregnancy more than 12 weeks, that is 12 to 20 weeks, we need 2 RMPs. I mean, we need advice of the 2 doctors to terminate that pregnancies. But now, if we will talk what are the changes in 2021 amendment, so then we will come to know that now the 1 RMP is required for the abortion till 20 weeks of the pregnancy, and 2 RMPs are required for the abortion till 20 to 24 weeks of the pregnancy. So this is very important. We should understand this thing, because why this has happened? Because there is potential outcome is this, we can increase in number of facilities, especially in our public sectors, PSCs, for the service provision till 20 weeks. So this is being done because we can increase our facilities at the PSC levels. Now, what are the silent features of MTP Amendment Act? Initially, MTP is permissible beyond 20 weeks only when it is immediately necessary to save the life of the pregnant woman. But now we have enhanced the upper gestation limit from 20 weeks to 24 weeks for special and vulnerable categories of the women, and further enhancement of the birth defects not compatible with life on medical board consensus. It means this, if we are going to do the abortion more than 24 weeks, then it is important that we have to take the permission from the medical board so that we can terminate that pregnancy. What is the potential outcome of this? This increases access for vulnerable women to safe and legal abortion services defined by the Rules Committee, includes violence victims, minors, among others. Now, what is the silent features of the MTP Amendment Law? The Act has provision for termination of such pregnancy only up to 20 weeks initially, but upper gestation limit does not apply in cases of fetal abnormalities diagnosed by medical board. Diagnosed by the medical board. So the important thing is this, that you can go for the abortion with the permission of the medical board by any age limit if the fetus is having abnormality which will not survive after the birth, or there is a mental or physical handicap of a grievous type, or is an injury the fetus cannot, the newborn child cannot take it to their life. Potential outcome of this is increase in the access to safe and legal abortion services, who often seek service late beyond the legal limit of termination. The most important advantage of this is this, that most of the time the females are not coming to us at right time till 20 weeks of the pregnancy. So there we are bound to say no to them that we cannot do your abortion. At that time they went to some persons who are not well qualified, who are not, I can say, they go for the places we are not qualified, they are just dyes and other things, and they got their unsafe abortion. The most important thing is this, if the child is not, if child is having a severe injury, a grievous injury, and child cannot survive after the birth, so we can go for the abortion up to any limit. Up to 24 weeks we can do, but after 24 weeks we have to go to the medical board and we can take the permission from the medical board to do the abortion of that patient. So this is very important, ki increase in the access to safe and legal abortion services, who often seek services late beyond the legal limit for termination of pregnancy, with substantial fetal anomalies diagnosed late, thus reducing the unsafe abortion and court cases. Now, what are the silent features of the MTPK Act? The previous Act, the condition of failure of contraceptives was applicable for only married women. But nowadays, condition of failure of contraceptive to be extended for any woman or her partner. Well, any woman of any age, either she is married or unmarried, she can go for the termination of the pregnancy if she is having the contraceptive failure. What is the potential outcome of this? Increased access to the safe and legal abortion for any woman, irrespective of marriage age, especially with upcoming changes in the legal age of the marriage. An important advancement for increasing access to the safe abortion. Now our government has increased the age to the 21 years. We all know that when the age of the marriage is increasing, that it means we will have more abortion in the females who are unmarried or who are of smaller age. I should say the adolescent or teenagers. In those patients, they can go for the termination of the pregnancy or MTP Act. In the MTP Act. Now, insertion of the new clause for strengthening the privacy. The Medical Termination of Pregnancy Regulation 2003 mentioned that information should not be disclosed except under authority of law. Now, what are the special thing is this? Even the name and other particulars of the woman whose pregnancy has been terminated shall not be revealed except to a person authorized by any law for the time being in force. Now, the potential outcome of this is increase in privacy and confidentiality of the abortion seekers, increased demand, but no need to safeguard the rights and dignity of the woman and provide respectful bias-free services, including counseling and contraception. Now, what are the silent features of MTP Amendment Act? The first is the prioritizing the confidentiality and safety, which I have told you, Abhi, the name and other particulars of any woman seeking abortion to be confidential, except to a person authorized in any law for the time of being in force. And the other thing is this. And the other thing is this, ki, एक second. बेटू ये फोन उठा लो, मैं बात नहीं करूंगी इस पर. And the man who is having the contraceptive failure can have the abortion. The other things which we should know about the what are the rules under the MTP Amendment Act? There are the three rules. Number one is the what we have to see in this act is this: we should know the special or vulnerable category of the woman. Who are the persons who can provide us the abortions? That is, what are the norms for the registered medical practitioners? And third is the powers and functions of the medical board. Now, if we will come on the vulnerable period, so what is the specially category of the women eligible for the MTP Act between the 20 and 24 weeks? We should know. The first important category is the survivor of the sexual assault, rape or incest. Second, women with pregnancy in humanitarian settings, disaster or emergency situation as declared by the government. Third is the change of marital status during the ongoing pregnancy. Patient may be widowed or she may take the divorce when the pregnancy is going on. So these patients can be categorized with the vulnerable females. The women with physical disability, major disability as per criteria under the Disability Act. And the other things, mentally ill women, including mental retardation, minors, and the fetal malformation that has substantial risk of being incompatible with life, or if the child was born, it would suffer from such physical and mental abnormalities to be seriously handicapped. So this is the group which is categorized under the special category of women special category of the vulnerable women who can take the advantage of the abortion at the 20 to 24 weeks of the gestation. What are the norms for the RMP? And RMP is defined in the old act as MBBS or more with any of all of these four. In this clause, there is not much changes except in the number of the cases. The medical practitioner assisted in 25 cases of MTP, of which at least 5 done independently in the hospital. The medical practitioner who has completed 6 months of the house job in obs and gynae, the practitioner who hold as graduate and postgraduate degree, who hold postgraduate degree or diploma in the obs and gynae, and the medical practitioner who has experience of at least 1 year in the practice of obs and gynae. So these are the qualifications which are defined for the RMP. And as all of us know, one RMP can do the abortion till 20 weeks of the gestation. 2 RMPs opinion are needed for the 20 to 24 weeks of the gestation. And the medical board will give the opinion for the abortion beyond 24 weeks. Now, what are the rules under Mtp Amendment Act? And now there is one more category which is being increased in the RMP under the amendment rules of 2021. An additional category of provider has been added for temptation up to 9 weeks with medical method of abortion. So this category is meant only for the medical abortions. Any RMP with experience in practice of obs and gynae at any hospital for 3 months. One thing. And the second thing is this: training with performance of 10 cases of medical termination of pregnancy by medical method of abortion under supervision of a RMP in a hospital established or maintained or training institute approved for the purpose by the government. So this is a new category which is being added for the medical method of termination of the pregnancy. Now we should know who can give the services. All of us know that these are the 4 categories of the RMPs. So now we have to understand that till 9 weeks of the pregnancies, these 4 categories and one newly added categories, all the 5 can give the medical termination of the pregnancy till 9 weeks of the gestation. When we are coming to the 12 weeks of the gestation, so only the 4 categories which I have categorized here, they can do the abortion. But whenever we are coming to 12 to 20 weeks, तो 12 to 20 weeks में जो लोग abortion कर सकते हैं, तो they are the only 3 categories. What are these 3 categories? One is the one person who is having the postgraduate degree or diploma in obs and gynae, one person who is having the 6-month house job in obs and gynae, and third is the 1 year in the practice of obs and gynae. So these are the 3 categories who can do the abortion till 12 weeks to the 20 weeks. And even after even 20 to 24 weeks, abortions can be done by only these 3 categories of the RMPs. Now we are coming the abortions more than 24 weeks. When the abortions we are supposed to do beyond 24 weeks, so there is only 2 categories. One is there is a degree of postgraduate degree, like diploma or MS, or another is a practitioner who have the experience of 1 year in the practice of obs and gynae. And the most important thing is this: beyond 24 weeks, we have to take the opinion of the medical board, and for the termination of the procedure, when advised by the medical board, is carried out with all safety precautions along with appropriate counseling and at an appropriate place. Now coming on the medical board. As we know, the medical board should be composed of a gynecologist, a pediatrician, a radiologist, or ultrasonologist. And what is to understand here is this: these are the district boards which should be, I should say, the state boards which are made for the termination of the pregnancy. Still, I don't know Uttar Pradesh is having any board or not. Already there is 178 boards which has formed. We need the regularization of these boards and the documentation of these boards on our website by the FOXI bearers, Dr. Santa Kumari, and by the WHO and other persons who are related to this ministry guidance, the FOXI and ministry guidance. We need all these boards on our websites. And there are the persons who can make the vote. So this is to understand that one person should be from the any medical college. He should be head of the department of the obs and gynae, and she should chair the board. The other person, one woman member should be there. She may be a pediatrician, and one female member from the government hospital must be there. And after that, we can include the specialist, that may be pediatrician, radiologist, or any other person, which is needed according to the case. And the other thing is this: board members can be substituted by another member if any member is absent. Suppose there is radiologist is absent on that day when you are discussing about any patient who has come to the medical board. So we can replace the radiologist. It's the authority of the chair of the board. Okay, he can replace any person, any specialist from the board. And we have to understand one thing more. Suppose when we need to change the specialist, suppose there is a patient with a child in womb, with a fetus who is having the congenital anomaly of the heart. In that case, we are supposed to take the advice from the pediatric cardiologist. So we can substitute a person, a specialist, with the cardiologist in that case. So this is very important to understand. And now if we talk about what are the powers of the medical board? The powers of the medical boards are to allow or deny termination of the pregnancy beyond 24 weeks of the gestation only after due consideration and ensuring that the procedure would be safe for the woman at that gestation, and whether the fetal malformation has substantial risk of it being incompatible with life, or if the child when born would suffer from such physical or mental abnormalities to be seriously handicapped. So the one thing is he can allow or deny for the termination of the pregnancy. But the second thing is this: the board can co-opt other specialists, which I have explained already. Now, if we will come on what are the functions of the medical board? The functions of the medical boards are to examine the woman and her reports who would approach for medical termination of the pregnancy. And the second thing is provide the opinion of the medical board in Form D. This is very important. In Form D, the medical board can accept or reject the request of termination of the pregnancy depending on the evaluation of that case. Really the abortion is needed or not needed. So once any medical board given her opinion, rejection, then acceptance, so that have to be followed. If the opinion is of rejection, then patient go for the abortion. And for the abortion, this is very important, when advised by the medical board is carried out with all safety precaution along with appropriate counseling within the 5 days of the receipt of the request for medical termination of the pregnancy. And the another most important thing is this: the decision of the board should come within 3 days. Whenever the applicant applied for her medical termination application, then the board has to give her decision within 3 days, and the abortion should be done within 5 days. These are the guidelines which we have to follow. And the abortions after 24 weeks should be at the appropriate site, advised by the board, and patient should be counseled. All the information should be given to the patient, how she should go, what is the plus point, what is the minus point, then the termination of the pregnancy should be done. Here, one thing to remember is this: FOXI has an important role to play in ensuring there are functional medical board in every state, as is stated in Mtp Amendment 2021. One of the most important change in the amendment is this: when you are doing the abortion for the minors, then the consent has changed. You are not supposed to take the consent of the guardians. In case of any minor, you can take the consent of a person who is more than 18 years and who is responsible and who is taking the responsibility of the patient of the procedure. You can go ahead for the abortion. So this is very important. So you can go for the abortion in the case of the minors by the consent of any person of the 18 years. And the other thing which I will like to emphasize again, the most important part of the medical abortion is the privacy. We should keep all the records without informing anybody. The second point is we have to maintain patient's dignity, and respectful approach is very important. So the patient can come to us at any time and we can give her abortion according to her needs. Thank you so much.
I want to add one thing. If you are doing the abortion of minor, age is less than 18 years, it comes under the POCSO Act. So you have to always have to inform the police before doing that procedure. Abortion on the patient, age is less than 18 years. It is must to inform the police.
Okay, Savita.
Stop sharing
I
your
think we
slides.
should move to the second module.
Yes.
Questions I think we will take in the last.
In third module, some questions, feedback questions are there, so all have to answer for certificate purposes. We stop sharing your slides.
Okay. Huh. मैंने stop कर दिया है.
ठीक. Is visible? My slides are visible?
Yes, yes. Now for the module 2, I invite Dr. Savita Tyagi. She is a very worthy secretary of Agra Society, and now she is presenting the module 2. Welcome, Dr. Savita.
Madam, click on this enable editing and then go to slideshow, madam.
Okay. Thank you, Kanchan, for your kind words.
From beginning, madam.
Okay now? Is it okay? Full screen?
No,
No, ma'am.
But my computer is showing full screen. You
just low on the right side, you press the reading view.
I have.
Or you can, madam, stop share and again you start share the slides, madam.
नहीं, इसी
Do
से
the
हो
same.
जाएगा. इसी से सबसे नीचे राइट साइड में बटन है.
राइट साइड में बटन है. अभी हो गया ना फुल स्क्रीन?
नहीं हुआ ना.
मेरे में तो हो रहा है. राइट साइड में बटन है. कौन सा वाला?
नीचे आते ना तीनों जो स्क्रीन डिफरेंट दिखाते हैं, रीडिंग व्यू एंड डिफरेंट 3 टाइप के.
मेरे में ना फुल दिखता है, बट आई डोंट नो कि वो वहां पर नहीं दिखता. मैंने
चलो आप इसी से
कर दूं ना, स्टार्ट कर दूं?
हाँ ठीक है.
चलो ठीक है, नहीं टाइम वेस्ट करने से कोई फायदा नहीं है.
बट ऐसे ना दिखाई नहीं दे रहा है पूरी स्लाइड.
ओके
आपको जो है उस पे फुल व्यू करिए, वो नीचे स्लाइड शो होगा उसको स्लाइड शो में कर दीजिए प्लीज. राइट साइड में बना आता है मग जैसा.
आपकी स्क्रीन जो बनी हुई है ना, उसमें स्क्रीन में फुल स्लाइड देख लीजिए.
मैं मग में करी थी फर्स्ट. नहीं दिख रहा ना सबको पूरा?
अभी तो है नहीं, अब तो स्टॉप करा हुआ है आपने शेयरिंग.
श्रीमन यू प्लीज स्टार्ट. श्रीमन.
Okay, madam.
Shriman, you start sharing screen. So second module is how to proceed for the abortion. You all are now aware कि in which patient how to up to 20 weeks, any RMP can proceed for the procedure, as previously only up to 12 weeks. It was only one RMP was able to perform, but now up to 20 weeks, any single RMP is required for the to perform the MTPs. So how to proceed for the MTP is shown in this module. Next, please. Next, please. So in this module, we are going to discuss about what are the existing guidelines, how to do the pre-abortion assessment, how to go for the medical methods of abortion and surgical methods of abortion. Next, please. These are some WHO global guidelines books which are shown in this slide. And in the next one, to some books, safe abortion books are for our country also. And there is a roadmap from 2020 to 2019. Please change the slides. To begin with, in 1971, the MTP Act was implemented in our country. Then some changes occurred in 2003, and in 2021, the very important amendment took place. Next, please. Next, please. So as we all know, this law was changed on 25th March 2021, and the rules changed on 24th September of 2021. You please change. And we have to know what are the guidelines for the safe abortion. So for in these guidelines, first thing is the pre-abortion care. This pre-abortion care means we have to take the detailed history of the patient, physical examination, general examination, lab and other investigation, and then discussing the contraceptive profile. That is very important. Every patient, if she is coming to you for the abortion, we have to always counsel her about the contraceptive methods, and also always ask her to opt any one of them. It is very important. And then one thing comes on the part of the patient. The decision should be kept on her side. We have to ask her to show or allow her to choose any option, whether she wants to go for the medical abortion or she wants to go for human aspiration. And we have to counsel her about what procedure will be good for her based on the duration of her pregnancy and her medical condition. So not only pre-abortion care, abortion care methods has to be asked for. We have to put in front of the patient, and after care and follow-up are very important for this patient. Next, please. Next slide. Pre-abortion assessment and counseling. Next, please. Next. As I have told you that detailed history taking is important. If patient is having any medication, if patient is having any history of allergy for any medication, or if she had any drugs for any other problem like kidney problem or liver problem, or she is a case of cardiovascular problem. So detailed history is very much important. Then we have to go for the general physical and pelvic examination. Physical examination, the blood pressure, pulse rate, and her cardiovascular assessment is also always important. And pelvic examination to assess the size of the pregnancy. And then lab and other investigations if required. Although according to guidelines, it is not must to go for the investigations, but it depends on you. If you think those tests are compulsory for the patient, go for these laboratory tests. Then comes the decision-making information on abortion procedure and counseling that comes on the patient's part. We have to put all types of abortion process in front of her, and we should counsel what can be the better. Then let her choose whatever she wants. We have to go for that. Next, please. Then this is the how to do the physical examination and how to assess the size of the pregnancy. As we all know, if pregnancy is less than 12 weeks, then only per vaginal examination can we assess the size. But If the patient is having fibroid uterus or multiple pregnancy, or she's having this vesicular mole, then it is not possible to assess the pregnancy by only per vaginal examination. In those cases, ultrasound is needed. So we have to always ask about the LMP and should try to see whether the size is corresponding or not corresponding. Sometimes the size may be less than that what patient is asking, maybe because of mistaken date, or sometimes patient is breastfeeding and she's confused, having some light line there, may not be pregnant, and sometimes the patient is having missed abortion, and the most important cause may be the patient is having ectopic. So always keep in the mind that problem may be there in patients, because ectopic is not very less common, very much. So many patients come when we see in our day-to-day practice. And this is shown how to assess. If the patient is having 12 weeks of gestation, it will be at the level of the pubic symphysis, at 16 weeks between the pubic symphysis and the umbilicus, and it is 20 weeks at the umbilicus, and after 20 weeks, each centimeter above the pubic symphysis will correspond to the size of the uterus. Next, please. So, as I have said, pre-abortion, these tests are although not necessary according to the guidelines, but it all depends on us. If we think we should go for the test, and pregnancy test is done, if pregnancy is unconfirmed, hemoglobin or hematocrit for suspected anemia, and RS testing. I think RS testing is must in every patient if she is a primary, and RS immunoglobulins, according to this guideline, it has to be done only when immunoglobulins are available. And HIV testing, counseling, then sexually transmitted infection screening usually performed during the pelvic examination. Other lab tests as indicated by medical history, patient, if you think a patient is a case of kidney or liver problem, then those tests has to be done. And ultrasound, although not necessary, but if you think a patient may be having ectopic or maybe having fibroid or twin pregnancy or molar pregnancy, you have to go for the ultrasound also. Next, please. Then pre-abortion care, what to do, what to ask. We have to ask about the why she came for the termination of the pregnancy and what are the reasons for that. Then we have to inform if patient is delaying for the abortion, ask her early abortions are safe, and also ask her tell her about the importance of a trained provider. If she's going to a quack, it may harm her, may lead into many complications. So always counsel her, if you are going to for the MTP, always go for a trained person, and also ask her, tell her about the available methods of abortion, and also the risk and warning signs. If she had bleeding or severe pain, she has to report immediately. Without contraception, she can get pregnant. That is very important, because so many patients come for abortion, they take medical abortion, they abort it, and in next cycle they again become pregnant. So it is not very uncommon, it is very common problem. So we have to counsel that if she is not using, she will not use any contraception, she may become again pregnant within 14 days of abortion. And how much time she needs for resumption of normal activity, we have to tell her, and including the sexual intercourse. And any other follow-up care, if patient is severely anemic or having any problem, we have to follow up for her general physical well-being. Then we have to document something like the written consent of the patient and decision to accept post-abortion contraceptives also has to be, we have to write down. Even if she is not willing for contraception, she will be provided with the abortion services. It is always must. Next, please. What are the recommendations? If the patient is having pregnancy less than 9 weeks, then medical method of abortion is advisable by Government of India. Although globally, this medical method of abortion is has to be done even after the 12 weeks of the gestation. But in our country, it is advisable only up to the 9 weeks. And these are the methods. If it is less than 12 weeks, mifepristone and misoprostol methods, and this is is advisable in our country. And misoprostol only vacuum aspiration is also advisable, and misoprostol we usually in our country it is not only misoprostol method is not comes in the regime. These mifepristone and misoprostol regime is advisable, but in globally in some countries only misoprostol method is also advised. Then if patient is having more than 12 weeks of gestation, mifepristone and misoprostol combination, misoprostol only, and dilatation and evacuation. It is dilatation and sharp ketrazine never recommended. So if patient comes up to until to 9 weeks of pregnancy, on first day mifepristone as we all give 200 milligram oral. Then after 24 to 48 hours, misoprostol 800 micrograms sublingual or buccal. On if the pregnancy is 7 to 9 weeks, it is written here because it is recommended by our country to give the 800 microgram, but outside 400 microgram is given up to the 7 weeks of the pregnancy. And in our country, if it whether it is up to 7 weeks or 7 to 9 weeks, misoprostol and mifepristone, these doses are same. Next, please. Next. So as we all know, method of first trimester abortions are either medical method or it is a vacuum aspiration, maybe manual or electrical. Next. Next. What are the how these mifepristone and misoprostol act? As we all know, mifepristone is an antiprogestin, inhibits action of progesterone. It interferes with the continuation of the pregnancy, while this misoprostol causes cervical softening, uterine contraction, and the expulsion of the products of conception. Next. 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 So as I have already told you, what are the protocols? If patients comes to you, day one, we have to provide a mifepristone administration orally, 200 milligram. 200 milligram. Then along with this mifepristone, if patient is RS negative, then 500 microgram of the anti-D is given at the same time. And on the we then call her on the third day, up to 7 weeks, as I have told, 400 microgram misoprostol has been advised, but we give 800 microgram of the misoprostol in our country, and WHO recommends 400 microgram of misoprostol. Sublingual can be given buccal, vaginal, oral, or oral. And if it is 7 to 9 weeks, 800 microgram sublingual, buccal, or vaginal is given. In addition, patients has to be given analgesics like ibuprofen. If patient is having excessive vomiting, then antiemetic, and also offer the contraception. If you are calling her on day 15, then confirm and ensure the completion of the procedure and offer contraception if not already done so. Next, please. Then what routes we can give the misoprostol? If oral routes is orally we can give, but it is recommended up to the 7 weeks for first trimester abortion, and if side effects are diarrhea, vomiting, and fever and chills. If it is given buccally, then buccal route, the pills are placed between the gums and cheek, and it is swallowed after the 30 minutes, and more fever and chills than with the vaginal route. In sublingual route also, that is the best route. This is we put this misoprostol under the tongue, and it is swallowed after the 30 minutes, but fever, chills, diarrhea, and vomiting are more, but it is the most effective method and fastest onset of the action. So the best route is the sublingual. For the point of view, the fastest onset of the action, and the plasma concentrations levels are also high. Vaginal routes are also good, but and because the side effects are minimal, but lowest and lower rates of side effect, but plasma concentration not as high as in the sublingual route. Next, please. Next, these are the pictures showing where to put in the buccal route and where to put the sublingual route, the tablets. Next, please. Next, please. Then what is WHO recommendation for the medical method of abortion? How to induce the how to give the medicines? If it is less than 12 weeks, 200 milligram per oral mifepristone, and day 3, 24 to 40 after the mifepristone, you have to give misoprostol 800 microgram, maybe buccal per vaginal or sublingual. If you are giving only the misoprostol, then it only 800 microgram tablet of this misoprostol is required. It may be given buccally, maybe placed buccal, per vaginal or sublingual. So ask patient, usually the bleeding takes place for 2 weeks after giving the tablets, but sometimes it may last up to the 45 days. In rare cases, it happens. Usually the bleeding stops between 7 to 14 days. Next, please. Next. So what we have to provide to the patient? What should be the provision? If you are going for giving the starting the medical abortion, what provision should you have? This service should be available at the primary care level, because so many doctors in our country are not qualified or not postgraduate. They are doing only MBBS and working at the peripheries. They have training of only 3 months, or having some MTPs, as has been said by the Dr. Aarti, they have assisted only 25 MTPs. So they all are now eligible to go for the medical method of abortion. But if they are doing at primary care level, they should have some good referral system in place for all required higher level care, because sometimes complications occurs. If it occurs, then they have to refer these patients, and they have to also give some additional services may need to be provided to individuals, because if some patients comes, patients have to be counseled for sexually transmitted diseases like HIV, and sometimes patients come and take tablets again and again. In such cases, these patients has to be counseled about the abuse support service has to be provided to these patients. And sometimes patients are very much depressed because they are forced by their husband to take the tablets again and again, to having psychological problems. So we have to support these patients psychologically, and we have to also provide the social services at the primary care center. And other specialist health or medical services has to be given. If patient is anemic, then iron has to be given, or patient is having pain, then pain medication has to be given, and emotional support is also given if required. Next, please. Then follow-up. It has been said that routine follow-up is not required. If we are giving this combination regime, mifepristone and misoprostol, then according to guidelines, this follow-up is not routinely required. But if it only misoprostol regime is used, then patients are called again at the 14th day to see if the abortion is complete or not. And if you think you have to call the patient, then call between 7 to 14 days, and we have to see to go for see if the abortion is complete or not. We have to give her counseling about the contraceptive methods, and we have to give her emotional support, or have to see if she is having any medical problem. Next, please. So what we have to do then? Follow-up care. Next, please. We have to see if patient has recovered from assess members at home recovery, and ask for any sign or symptoms of ongoing pregnancy, because sometimes these medical abortions, patient has taken the tablet, but even then pregnancy continues. So we have to confirm whether if she is still having the sign and symptoms of pregnancy, and we have to review any available medical records and referral documents कि क्या हमने इस मरीज को कोई कॉम्प्लिकेशन हुआ था या इसको हमने कहीं भेजा था, तो हमें वो सारा चेक करना है. And ask about any symptoms experience is the procedure, and perform a focused physical examination for any complaints, and assess women's fertility goals and need for contraceptive services if not provided earlier. हमें देखना है कि if this patient wants to bear child in her future, then we have to provide her contraceptive methods as required according to her requirement. Next, please. Next. So what is the, in summary, what's the medical method of abortion? Next, please. Day one, I think everybody now knows ki day one we have to do the physical and pelvic examination, confirm eligibility. Up to 47 weeks, tablet mifepristone, oral anti-D for virus negative women. Tell the women return for misoprostol administration after 2 days. We have to always provide her contact address and phone number of the facility center where she can go in case of any emergency. ये नहीं कि दवाई दे दी और छोड़ दिया कि अब उसको जो हो रहा है तो वो झेले. तो we have to always give, even the person is working at the primary care center, she has to give her numbers of the place where she can go in the emergency and record her experience of any side effects on the medical method of abortion card. We always write down if she experienced any side effect so that it will work in future for her. And it has been said that 3% of the women who took this mifepristone, they abort. But even if she has aborted, always give them misoprostol, never skip it. Then we have to complete the schedule after giving the misoprostol. Next, please. Next. You have called her on day 3. Then we have to give her misoprostol 400 micrograms sublingual, buccal, vaginal, oral as you wish, and ask her to live there, to stay with you for at least 4 hours, and also provide her tablet ibuprofen of 400 milligram, and also advise her for contraceptive options. If she wants to take the injection, injectable can be given at the same time. If she wants to take another option, then advise her to take another options also, and tell the women that mean period of bleeding is 8 to 13 days, and possible side effect may be nausea, vomiting, diarrhea, headache, fever, dizziness. And if she is having, both in cases of either she is having excessive bleeding or having the severe abdominal pain or fever, and report if there is no, she has also to report if she has taken the misoprostol and there is no bleeding even after 24 hours after the misoprostol. Then again we have to consider for giving the additional dose of the misoprostol. And it has been seen that 75% women abort within 4 to 6 hours after misoprostol administration. And then third visit should be at the day 15. What to do? Again, we have to see whether the this procedure is complete or not by doing the pelvic examination, and also provide the contraceptive options. If she wants to go for the sterilization, then we have to wait for one menstrual cycle, and then tell the woman about immediate return to fertility, as a patient may become pregnant even after the 14 days of the abortion, and ask her to report if there are no periods within the 6 weeks of completion of the abortion process. And ultrasound is only advisable if you confirm that the procedure is not complete. Next, please. Then we come for the side effects and complications. What are the complications? The side effects are, patient may, as have been discussed, may have the fever, diarrhea, and vomiting or pain. For pain, we have to give some analgesics to the patient, and for diarrhea, reassurance is enough, and vomiting also we can reassure the patient. Please change the slide.
While you do that, can I request Pratibha to not, use the pencil because you're marking the slides? Yeah, carry on. Yeah.
Okay. Thank you, sir. Thank you. Pain. If patient is having pain, always respect her problem. Not judgmental communication should be there. We have to support her verbally. We have to do the adequate counseling of the patient, support her, give her analgesics like ibuprofen 400 milligram. Even if the patient's pain is persistent and it is not responding to the drugs which we are providing to her, then we should it warrants, we have to evaluate for other cause like ectopic pregnancy or infection or incomplete abortion. So if pain is there, we have to evaluate fully to the patient. And as I said, if patient is nausea and vomiting, reassure her. It can be maybe self-limiting, and diarrhea also. Reassurance is enough. But if the patient is having infection and we find by physical examination, then we have to start the antibiotics. Next. Next. If it is there is failure of the medical method or it is incomplete to do. If the medical method abortion fails, so we have to either offer her vacuum aspiration or we can repeat the medical method of abortion. But if it is incomplete, we have to observe the bleeding is not heavy, and so then we have to wait and watch and see the when bleeding stops. We have to see whether uterus is normal size. If it is normal size, it means abortion is complete. But if in the bleeding is heavy and it is not stopping, or then we have to go for the we have to go for the surgical method of abortion. And if it is incomplete and bleeding is not there, we can repeat the misoprostol tablets also. So heavy bleeding, then vacuum aspiration. If not, it is not heavy, then repeat misoprostol. And if it is not heavy, and we can, then we can wait and we can see if it may takes more time. Sometimes it takes more time, so we have to wait and watch to see if it is complete or not. Next, please. Suppose patient is having excessive bleeding. It means in 1 hour, 2 pads are soaked in for 2 consecutive hours. And we have to watch over the signs, vital signs. And if she is stable, then we can wait and watch, and bleeding is decreasing over the time. Then after the patient, if she is settled and bleeding becomes less with time, patient can go home. But if bleeding is still continuing, it is not decreasing, the amount is still very much, then we have to watch vital signs. We go for the pelvic examination. And if we find products are in the cervix, do the finger evacuation or digital evacuation of the products. Wait and watch. Patient settles, bleeding stops, patient can go to home. But if even in spite of that, bleeding continues, then we have to go for the ultrasound. And if the ultrasound shows only minimal residual bits, watch. If there are a lot of products are there and patients stable, then we can repeat the misoprostol 600 microgram oral or 400 microgram sublingual. Or if patient is not stable, then vacuum aspiration has to be done. Or if the patient there is pregnancy is continued, then also vacuum aspiration has to be done. Next, please. Next. Then what records we have to keep? Since medical method abortion is also under the Mtp Act, so the documentation is similar to that required for the vacuum aspiration procedure, and it is mandatory to fill all the following forms. Form C, as we all fill for this vacuum aspiration, has to be filled for this medical method of abortion also. That is consent form. Form 1, RMP opinion. Form 2, monthly reporting form, and Form 3, admission register for case record. So recording is must. We have to keep all the records of medical method of abortion patients also. Next, please. Now we are coming for the vacuum aspiration and vacuum surgical method, that is vacuum aspiration, maybe manual vacuum aspiration or electrical vacuum aspiration. Manual. Next, please. WHO recommend to go for the manual vacuum aspiration. In our country, we go for medical method up to 9 weeks, and beyond that, we have to go for the vacuum aspiration. And WHO recommend manual vacuum aspiration as the safest method, and that these procedures should not be routinely completed by the sharp curettage. Next. In vacuum aspiration, we this is a MR syringe is used, and this is a handheld aspirator. It used to generate the vacuum, and aspirator is attached to cannula 4 to 12 millimeter in diameter, and cannula can be used in multiple times and settings, including those without electricity. And these are the two types of cannulas, that is IPSA or easy grip cannula size. And these cannulas correspond to those has to be used according to the size of the pregnancy. If the pregnancy is of 8-week size, 8 millimeter cannula is used. And if the 10 weeks gestation is there, then 10 millimeter cannula has to be used. Next, please. Next, please. Second method is vacuum aspiration by the electric vacuum by using the electricity. It is an electric pump used to generate vacuum, and it can accommodate cannula of the manual vacuum aspiration with correct size tubing. Then comes the manual aspiration, vacuum aspiration. Then in vacuum, please change the slide. In manual vacuum aspiration, first we have to first, before going for the procedure, we have to do the cervical ripening also, so that prepare the cervix and make it soft and easy to dilate. And what are the recommended method for cervical preparations before surgical abortions? If either give the mifepristone 200 milligram of 24 to 48 hours in advance, or misoprostol 400 microgram administered sublingually 2 to 3 hours prior to the procedure, or 400 milligram misoprostol vaginally 3 hours prior to the procedure, or laminaria can be used intracervically 6 to 24 hours prior to the procedure, so that we can we can dilate the cervix easily. Next. Then how to manage the pain. When we do the procedure, patients are very much anxious, and we have to do the pain management. It can be have non-pharmacological, or we can do by the pharmacological methods. Next. What are the non-pharmacological methods? Next, please. We have to tell the patients all the steps in advance to allay her anxiety, and we should provide her psychological support. And we have to perform the procedure gently, smoothly, and politely. We should be very polite with the patient when we are performing the procedures, and always encourage the woman to relax and breathe deeply, and engage her in talk with her when we are doing the procedure, so patient's attention is diverted. It is not very big task, because when we were doing these MTBs in Mary Stopes clinic, we usually used to talk to the patients, and we never gave any general anesthesia. We used to give the paracervical block, and all patients were very much it was very much supportive, and it was possible to do the procedure even without doing the general anesthesia or diazepam or any other this pharmacological method. Next, please. Next, please. Then the pharmacological methods. Then we have to see if the patient is anxious, then we have to provide the anxiolytic like diazepam. It can be given oral or IV. The dose is 10 milligram. Effects last 4 to 6 hours, and side effects are disorientation and dizziness. If the patient wants general anesthesia, it can be given. Then we have to call the anesthetist. And then patient may having the pain during the cervical dilatation. For that purpose, we can give the lignocaine or local anesthesia. It is given in the dose of 10 ml, 1% lignocaine is given in each fornix, and effect lasts for 60 to 90 minutes. Side effects are dizziness or seizures. And second is the analgesic ibuprofen. It can be given 400 to 800 milligram 1 hour prior to the procedure, and gastritis is the side effect. Then if patient is having uterine cramping, then analgesic ibuprofen 400 to 800 milligram 1 hour prior to the procedure, and last 4 to 6 hours, and side effect are gastritis. Next, please.
Can I request Sangeeta Malhotra to please mute yourself?
Then what are the steps of manual vacuum aspiration? Please go ahead. Change the slide. First step is the preparation. We have to close the valve button and create the vacuum. Second is the step 2, ensure the pain control medication is given at the appropriate time. Usually half an hour before we start the procedure, tablet ibuprofen 400 milligram is given to the patient, and then ask the patient to empty her bladder. Then we have to do the cervical preparation by antiseptic method. Step 4, we have to administer paracervical block by injecting the 10 ml of 1% lignocaine in each cornices. Then dilate the cervix, and step 6, insert the cannula. Step 7. Next, please. Suction is given. We have to withdraw cannula 1 to 2 centimeter away from the fundus inside the uterine cavity, and rotate the cannula in 10 to 2 o'clock position with smooth, gentle motion, and release the vacuum button on the aspirator before withdrawing and rotating the cannula. Next, please. Then we have to see whether this procedure is complete or not. Then how can we see if the red or pink foam is coming foam without the tissue passing through the cannula, or there is tetty sensation, or cervix creeping over the cannula, or uterus contracting around the cannula. And step 8 is we inspect the tissue whether all the POCs are corresponding to the size of the gestation. Then step 9, we have to do the concurrent procedure. If patient is willing to IUCD, we have to book the IUCD, or if patient has to go for the sterilization, we have to complete that procedure. And we have to then step 10, we have to do the instrument processing, like instrument to be soaked in chlorine solution 0.5%, and assist in disinfection, which not only by this not only clean these instruments, but also assist the disinfection and helps the remove tissue and body fluids. Next, please. Then what care we have to give after the procedure? Monitor her for any complications and provide management as needed. She may leave the facility when she is stable and meets the criteria for discharge. Ensure that the woman has all necessary information and medications prior to leaving the facility. And we have to document all the treatment and outcome, including any adverse effect, even in the facility register and client's record card. It is must. If patient had any complications at the time of procedure, we have to write down not only in your own register, but also on her card. Next, please, for future purposes. Next, please. And then what is the aftercare? Management of abortion complications has to be done. If patient comes with incomplete abortion, we have to do the evacuation in cases of medical method of abortion. If patient is having infection, we have to provide her in antibiotics. If bleeding is there, when it required, then vacuum this surgical evacuation has to be done. Or in ongoing pregnancy is there, then we have to go for the evacuation. And we have also give her the provision of contraceptive information, and always offer contraceptive counseling and methods. And patient having any other issue like sexual or reproductive health, we have to take care of that also. And follow-up, no routine follow-up unless meso alone regime is used. It is a new recommendation. Thank you. Next, please. I think this, in summary, India has made historic progress in improving access to safe abortion. As we have said before this 2021, it was not advisable to go for abortion after 20 weeks, even the patient is having the malformed baby. Sometimes such ladies used to go to those quacks, and the complication rates were very high. So India, it is an historic progress in 2021 by increasing the size of termination of pregnancy. And although the technology is not much changed, but the safe abortion is now on higher side as the amendment of the law are there. Not only because of this malformed baby, but although these minor girls and widows and divorcee all were suffering in past. As provided, it is up to us to ensure safety and quality, especially in context of the amended law. Along with safety, we also need to focus on respectful abortion services. And whether we are in public sector, the sector or private sector, every patient, we have to inform her all the things. We have to educate and equip with proper information on contraception and counseling. It is a responsibility of all gynecologists. Next, please. So when our participants, when they will attend all these 4 modules, they will have one certificate from our FOXY, and this program is in not of only FOXY, but also with the WHO. So in India, abortion is legal. Let us make it safe and respectful. Next, please. So this was the second module, how to do the procedure, how to do the counseling, and how to go for the complications, and what is required pre-abortion care, what is pre-abortion care, and what is the after-abortion care. Not only the procedure is important, but pre-abortion care is equally important. Unless we do the pre-abortion care nicely, we can miss the so many things, and there are chances of having the complication in the patients. And we have, it is our duty to counsel every patient to take the contraception. And when we are doing the procedure, always write down what contraception she is adopting. That is must. That it should be done, because मुझे लगता है कि we all have this experience कि patient coming to us for the abortion, going after abortion, she only after 2-3 months she again comes to us having the another unwanted pregnancy. So it's our responsibility to make to ensure patient to take some contraception along with the abortion.
Thank you. What is the next module? Coming on the next module, Dr. Savita.
Yeah. Please share the next one.
Next one is whom?
Shriman will share, because I am not able to do the full.
Wait, the next one is yours?
Yeah,
or after that?
Yeah.
So
small
please
module is.
hurry up, because the time is.
Yes. It is a small module. I am not able to do the full screen now. That is the problem. I don't know what is happening with me. This module is 7 module. This is mainly concerned with the respectful abortion care of the women. Previously, we were worried about the legal and illegal abortion before 70. Then comes the safe abortion in 2003, and now it is the respectful abortion care.
This is 3B. You have to present 3A.
Yeah.
So this is 3B. This is mine.
3A, please.
Shriman, please share 3A, 3B. I have
Yes,
to
madam, I'm
forgive
doing,
that.
I'm
I'll
doing.
check.
Okay, while Shriman is trying to get to the slides, good afternoon, everyone. It's
Thank you.
absolutely
Good
wonderful
afternoon, sir. Good
to
afternoon.
be here and listen to each one of you. It has been absolutely a delight, and huge congratulations to all the individuals who are participating and also combining the Agra and the Kanpur Society. It's first of a kind that we have done, and full marks to each one of you to have made it
Thank you so
possible.
much.
Especially
Thank you, sir. Thank you. Thank you so much, sir.
And I will have to leave the meeting now. I have already posted for you, Kanchan and Savita,
Yeah.
direct messages, which has got a link, so that at the end of the session, post that in the chat box, so that every participant can click on the link and
Okay,
go
sir.
to the post test and feedback section. तो वो लिंक जो चैट बॉक्स में पोस्ट होगा उसको आप क्लिक करेंगे और क्लिक करने से आपको पोस्ट टेस्ट और फीडबैक का लिंक ओपन हो जाएगा जहां आप वो सबमिट कर दीजिए ताकि आपका ये पूरा कोर्स कंप्लीट हो जाए और सर्टिफिकेशन हो जाए.
Okay. This is very important announcement. Yeah.
Yes.
आप emphasize कर दीजिएगा लास्ट में. ठीक है?
Okay, sir.
Thank you so much. Have a wonderful session.
Thank you, sir.
Thank you.
So this is module is SAVER module, and it means safe abortion values, evidence, right, and respect. Next, please. And what the aim of this module is? The aim of this module is to define what is the respectful abortion care, what according to WHO standard, and highlights how norms and stigma affect our services, and it's provide WHO saver resources for RAC. And next is momentum has been changed. What is the respectful abortion care? It refers to that maintains safety, dignity, confidentiality, ensures freedom from harm and mistreatment, and enables informed choices and continuous support during and after all types of abortion. So we had next, please. One slide you have skipped. Now because momentum has been changed because Foxy is the largest provider base for abortion care. That's why the online, and because of the COVID, it was possible to do the online training to all the members of Foxy, and medical method of abortion uptake increased because we do it in early before the 9 weeks, so it is safe, and it ensures no PCPNDT conflation. And in this module, our main aim is we are concerned with the patient safety, respect, and quality which we provide to the patient. So what is respectful abortion care? As I have already explained you, and what are the norms and stigma? Next, please. Then there are some category of disrespect and abuse. Next, please. No RMP can use any physical. Previous one, please. Previous slide. Previous slide. Next one.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation. especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others personally and professionally.
Before finishing this, some disrespect and abuse are categorized as if you are using a physical abuse to the patients, like you are slapping her or intimidating physically, and if you are giving any verbal abuse to her, non-consented care, it also comes under the verbal abuse or shouting or screaming, or sexual abuse in the form of abuse of power, taking advantage, and failure to meet professional standard of care, poor rapport between women and provider is there, then it also comes in disrespect and abuse. And if health system condition and constraint, and it is the right of every woman. It is to freedom from the harm and ill treatment, and it's also her right to information, her protection under the law like MTP law, POXO law. Informed consent has to be given. It's up to her whether she gives the consent or refuses it. And also respect for choices and preferences, her dignity and quality of care. It is very important for every woman. And her right is also her right to timely health care and to the highest attainable level of health liberty, autonomy, self-determination, and freedom from caution. So this is very important. we have to respect if she is coming to us to give her respectful abortion care. Next, please. One more slide is there, then we will finish this module. So what are the domains of respectful abortion care? Being free from harm and mistreatment, maintaining privacy and confidentiality, preserving women's dignity, respecting women's choices, engaging with effective communication, soft skills, providing information and seeking informed consent, ensuring continuous access to support, enhancing quality of physical environment and resources, and providing equitable abortion care to her, and also availability of competent and motivated providers. And there should be provision of contraception advice and commodity security and continuity of care and counseling. Next, please. Next, please. Next.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO SAVA, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO SAVA toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. SAVA has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVA is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
I think this module is over now.
Stop sharing.
Oh, madam, still we have PPTs.
Pardon?
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent Mtp Amendment of 2021. Use of mother, father, parent during a pregnancy is value-laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the Mtp Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex-selective abortion is illegal. Provider and place need to be safe, trained, and certified.
Now some question answers are there and everybody has to give the answers. You just skip this and come to the questions. And please put your, now you have to recapitulate what you have learned in these modules, and please in chat box give your answers. Please come to the question answers.
Ma'am, more 7 slides are there, ma'am.
Pardon?
More 7 slides are there.
I have tried to out 4 slides out of 5 slides out of that. I think 2 slides were left. Okay. According to the WHO organization restricting question number 1. Question number 1. You are back, please back. Yes, according to WHO organization restricting access reduces the number of unsafe abortion. Whether it is true or false, please write your answer in the chat box. Answer is false. So those who has written the answer false, they are okay. Next question. Next question, please. Next slide. The Mtp Amendment 2021 requires a minor less than 18 years to obtain written consent from parents, guardians before she can undergo a termination of pregnancy. It is true or false? Please give your answer in the chat box. Answer is false, because if the patient is age is less than 18, if she is minor, then we need to provide service. We have we have to always give the information to the police, because it comes under the POCSO Act. So only the signature of her parents or guardian are not enough. Before going to the procedure, we have to always inform the police. Otherwise, we will be in the problem. Next, please. Next. Please don't change the slide unless I ask. अभी इसको बदलना नहीं, श्रीमन, please. 30 years old women recently widowed wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Yes or no? Yes. Change the slide, please. Change the slide. Yes. Those who have written the no, it is okay, because up to the 20 weeks of gestation, one RMP is required, and for between 20 to 24 weeks, 2 RMP's opinion is required. If the patient is widow, or if she is divorcee, if minor, these all cases, or if she is mentally retarded, insane, or physically handicapped, all these patients can seek the MTP up to the 24 weeks of the gestation. So it is not our responsibility to tell her to continue this pregnancy. Okay. Next, please. Next question. Next slide. Okay. These are the questions. And now you please just check how many of you have given the right answers. Shriman, can we move ahead? Now I invite Dr. Kanchan to. Dr. Kanchan is a secretary, very active member. She is now contesting the election for the post of committee chairperson for this breast committee, and she will take the last module.
First of all, I want to, I am audible?
Yes.
First of all, I want to thank you, Dr. Savita and Dr. Aarti for nice words, and Dr. Shanta Kumari, who has planned this excellent module, and the National Observer Ajay ji is there, Shriman to help us is there. I want to thank you all. To succeed in your mission, you must have a full-heartedly devotion to your goal. So we by these modules and nice presentation which you have seen, are doing our best efforts, because the work that requires dedication and perseverance. So we are giving our time, energy, which is very important for its success. So this module 3B, that includes pre and post-abortion FP counseling, leveraging technology for referral and online consultation. This is by the FOXI and the WHO initiative. This is a joint initiative. I am Dr. Kanchan Sharma, Secretary of Kanpur Obstetrics and Gynae Society, and today's master trainer. Actually, this session has to be taken by Dr. Narendra Mehlotra. He is busy somewhere, so I am the master trainer to take this session. So what about the counseling? This is very important. The counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feeling and perception. तो काउंसलिंग क्या है, हम मतलब उसमें पेशेंट्स को प्रॉपरली विथ फुल प्राइवेसी वी काउंसिल, सीइंग हर इमोशंस एंड ऑल. Pre and post abortion counseling is very important. This is an integral part of comprehensive abortion services. It is as important as the procedure. Procedure जितना important है, उतना ही important counseling है. Counseling बहुत ही important है, and we should pay sufficient time to counsel our patient. Otherwise, the complications which we have seen, they happen. Women may need a help in decision making. Many times it happens, the woman come to you and wants a decision that whether, ma'am, there are a few complications or not, whether we should go for it. You should very politely try to help her. Wherever needed, the spouse should also be counseled. This is very important. When the woman is there, you counsel her. If she is with her spouse, better to accompany the spouse. So what is the pre-procedure counseling? You should help, ensure, and again help. What is help? Help women to decide about the termination of the pregnancy. You see and counsel her. Second, help the woman to choose the method of termination. Give so many other methods. This is the medical method. This is by the suction evacuation. You help her and ensure the delivery of the complete information about the procedure and help women to adopt a contraceptive method. That is again your duty. So what are the pre-procedure counseling procedure? These are ensure privacy. This is very important. First of all, you have to ensure privacy and confidentiality. Be non-judgmental and be sensitive. This is very important. Be sensitive. As in all scenario, you must have seen in the busy government setups and all, they used to scold so much to the patient. That should not be done. Establish a rapport. Use simple language and allow the woman to clarify her doubts. If she has made up her mind for termination of her pregnancy, assess her for the procedure. This is better that you assess her procedure and give a very humble advice. So, what is the relevance of peri-abortion counseling? It will quick return of the fertility, and there is a opportune time for contraceptive acceptance, and minimum 6 months gap before the next pregnancy should be there, health benefits and the better future pregnancy outcome. So that is a proper time that when the patient comes to you for the abortion, you very politely, very humbly guide her to choose the method and for the further contraception. This is the very important window when the patient grasps your all the things for the contraception even. The pre-abortion FP counseling, when to start and what to counsel. This is very important. When to start? First visit for the consultation. When the patient comes on the first visit, and exception is the grief management delay. Many times the patient is in grief and you have to manage her at emotional level. What to counsel? The importance is you counsel her the return of fertility that happens sometimes 10 days to 4 weeks. So help her to choose the devices. Give the different options. These are the oral pills. These are the injectables. These are the intrauterine devices. Help her to choose what and where and what are the contraindications and which is most suitable to you. Methods, specific counseling, high risk behavior wherever applicable. If the woman is not willing for any contraceptive method, then even many times we have seen, हमने लोगों को कहते देखा कि अब तुम इसके बाद कोई contraception use नहीं करोगी, मैं जाओ तुम्हारा नहीं करती. This is a very vague way to speak to a patient. Be humble, be polite, and humanly behavior. Try and counsel her after the procedure even. If she is still not willing, call her for follow-up in a week's time and counseling again and again involving her relatives will improve her acceptance. And that is our motto. That is the motto of respectful abortion care. So assessing the suitability, general guiding rules, what are these? These are abortion processes complete. We have to see, and there is no existing infection that is to be seen. and there is no injury to genital organ, and chances of the fresh pregnancy ruled out. That is by advising the proper contraceptive devices. What is the post-procedure counseling? You have to ensure that woman has understood precautions and care needed during the post-abortion period. Very important and opportunity. This is a very important opportunity to counsel for the contraception in case not previously accepted. Reinforce the method. It reinforces the method for continuing the use of contraceptive method chosen. That is, मतलब जब आप बाद में बुलाते हैं तो you can counsel her better. Suppose किसी ने पहले आपकी बात मान ली, that is okay. Otherwise, this is your duty that you make your patient to understand the proper way and proper contraception, and by counseling again to the patient and to the relatives, they will accept your thing. Post-procedure counseling. What is this? Continue to ensure privacy and confidentiality. This is again reassure her in case of any problem. Repeat the information about the post-procedure care and tell her the danger sign. This is very important. If she has already opted, then appreciate that you have opted this, and this is for your beneficial effects of your health. Immediate care can be given by IUCD, by medroxyprogesterone acetate, or by ongoing oral pills, and follow-up protocol should be explained to her, and continuity, reproductive intuition, and make the cards for her. If in case she is undecided, LA anxiety because she is anxious and taking many of the things of her life, so better उसको अच्छे से समझाइए, console करिए, उसकी anxiety को LA करने की कोशिश करिए. Importance of immediate adoption and the chosen, उसको बताइए कि immediate अगर आप ये करा लेंगे तो उसकी क्या importance है. और in case extended period of adoption अगर आप बाद में करते हैं, अच्छा तो सोच के आइएगा घर से, फिर हम आपको बताएंगे, फिर इसमें से कोई मेथड आप अडॉप्ट कर लीजिएगा. दैट इज अ प्रॉपर वे. कपल काउंसलिंग. अच्छा, कपल को बुला के समझा दीजिए, और कई बार ये इसी पिल्स वगैरह भी, इमरजेंसी पिल्स भी हैं, इन केस अगर वो लेके आते हैं तो यू कैन एडवाइज. व्हाट आर द पोस्ट एबॉर्शन कॉन्ट्रासेप्टिव मेथड्स? इसमें अगर टाइमिंग्स आफ्टर एबॉर्शन, अगर फर्स्ट ट्राइमेस्टर में आती है तो बैरियर मेथड पहले तो है, ये कंडोम है. एज सून एज द सेक्सुअल एक्टिविटी इज रिज्यूम, you can advise barrier method, even the first trimester and even the second trimester abortion after. What are the additional information? You can say no hormonal side effects, can be used without consulting a health provider, easily available, and prevention again STI is there by the condom or the barrier method, including HIV, and enable men to take the responsibility of the contraception. This is the advantage of condoms that you should make understand. अपने सब पेशेंट्स को आपको बताना चाहिए. What is the post abortion contraceptive method? Shriman,
displays the complete part with the file name.
Please see the disturbance. Post abortion contraceptive methods. These may be after the first trimester,
Created by placing
after the second trimester, and intrauterine. There's some disturbance.
Mute yourself, everybody, please. You are requested to mute. Shelly, please mute yourself. Shriman, mute to everyone, except Dr.
Intrauterine contraceptive devices. Intrauterine contraceptive devices are IUCDs 380 or IUCDs 375. So after the first trimester abortion, it is inserted immediately or up to 12 days after the confirmation of a completed abortion using the surgical method with MMA. That is medical abortion. Inserted around the day 15 of the process and provides complete POC expulsion, that is confirm. First confirm that there is a complete POC expulsion, and risk of presence of infection or any other contraindication is ruled. So you rule out कि कोई infection तो नहीं है, कोई remaining products तो नहीं है, फिर उसको advise कर सकते हैं even first trimester के बाद immediately IUCDs वो हम लोग सब पहले भी सीखे हैं, तो वो advise करना चाहिए. Can be inserted in the second trimester abortion, can be inserted immediately or up to 12 days after the procedure is complete and contraindications are ruled out. This is very important to advise, but see for the contraindications and better to counselor. And what are the additional information which is to be given? That these methods are highly effective and provide long-term contraception from 5 years, that is IUCD 375, or 10 years, even IUCD 380A, and can be provided by trained doctors, MBBS and above, ANMs, NMs, nurses after the first trimester, and surgical abortion by trained doctors only after MMA, and by the PP IUCD trained doctors after second trimester abortion. We put a thread, or we even apply after the second trimester when the uterine size is big. No interference with the sex, immediate return to fertility on removal. These are the advantages जो कि आपको समझाने हैं patient को. There are no hormonal side effects. And what are about the hormonal contraception? आप patient को समझाएंगे that combined oral contraceptive that you can take in the first trimester अगर आपने abortion करवाया है तब immediately or up to 7 days after the abortion using surgical methods. With MMA, it can be started on day 3, that is medical termination, with the dose of misoprostol or within day 15 of the process after confirmation of the complete abortion. And the second trimester abortion, immediately or up to 7 days after the abortion, you can start this. What are the additional information which you have to give to your patient? These are regulate menstrual cycle. These actually you can make them understand कि OCs आपकी menstrual cycle को भी regulate कर सकते हैं, and can be provided by all the health workers after the first screening by the trained provider. There is no interference with the sex. Offer protection against the ectopic pregnancy, endometrial and ovarian carcinoma, very important, and benign diseases such as fibrocystic and fibroadenomatosis. जब आप उसको ये सब समझाएंगे तो she will accept your counseling methods. Not suitable for women who are breastfeeding babies less than 6 months old. This is very important. ये आपको भी पता है, आप patient को भी समझाएंगे. What are the post again about the hormonal contraception methods which are long term injectable? These are MPA, medroxyprogesterone acetate, after the first trimester abortion, immediately or up to 7 days after the abortion using surgical methods. You can advise. With MMA, that is medical abortion, it can be started on the day 3 with a dose of misoprostol. Very important, in the second trimester abortion, immediately or up to 7 days after the abortion. What are the additional information which you will give to your patient? आप उसको बताएंगे कि ये highly effective है. Confidentiality and the privacy maintained है. आप आके लगवा लीजिए, आपके घर वाले पूछेंगे कि रोज ये क्यों क्या गोली खा रहे हैं. In case you are willing, can be provided by the doctors, nurses after screening by the doctors for the first injection. There is no interference with sex. Very important. No effect on the quality and the quantity of the breast milk. This is again very important point to be highlighted. No estrogenic side effect. It offers protection against the ectopic pregnancy, ovarian cancer, iron deficiency anemia, and the uterine fibroid. These points are to be highlighted. And what about the permanent methods? That is a female sterilization. After the first trimester, it can be performed after an abortion in the absence of any infection or severe blood loss concurrently or up to the 7 days. Both mini-lap or the laparoscopic method can be used. Sterilization can be done with MMA. If the patient is taking the medical abortion, it can be done only after the first menstrual cycle, after MMA. Second trimester abortion, mini-lap sterilization can be performed concurrently or up to 7 days after an abortion. Usually, ye second trimester abortion and mini lap is being combined, and much of schemes of PSI etc. were there. You have to see about the infection and the blood loss. Here, the laparoscopic sterilization is not recommended after the second trimester abortion. And what are the additional information which you have to give? There is a permanent method of contraception. It is a permanent method of contraception. So this is beneficial for you. It is highly effective immediately, and no interference with the sex, no effect on the breastfeeding, no long-term side effects, offer protection against the ovarian cancer. These are the things. And vasectomy, which is very important, that is to be adopted by the male population, performed on the males, and this is independent of the timing and procedure of the abortion. आप मेल्स को समझाएंगे कि आपके लिए बिकॉज योर सेक्स ऑर्गन इज आउटसाइड द बॉडी एंड दिस इज अ वेरी स्मॉल प्रोसीजर एंड very important that you can rather than in case your wife is having some problem, you can adopt this method, and this is very effective. It is a permanent method of contraception and no interference with sex, no long-term health risk, and couple must use contraceptive method with MMA. So after medical abortion, COCs can be given on third day, injection can be given third day, Centroman on third day, and IUCDs on 15th day or immediately, as I have explained in different cases. So these are the different things. COC injections, SENT and IUCDs can be given. SRH services, or now coming on the SRH services, teleconsultation and the other technology. So safe. Now, because after COVID, we have seen that telecommunication method has grown up. And we all should understand about this and have a full proper ideas about it. This. So teleconsultation, telecounseling, teleguidance, and tele-references and tele-linkage has come more and more into popularity. There are websites like Humdo, social media, Ask Tanu, YouTube, infographics and helpline and patient education platforms, WHO, RCOG and others on which the patient can log in and get the sufficient information about it. So what is the SWOT of teleconsultation? It is strength in COVID area. Because in COVID area, we all have started consulting on the teleconsultation platforms. This avoids the infection traversing from the patient to us or vice versa. Approachable throughout the process, and patient should develop the confidence. Their awareness spread out and question answer, they are answered at ease. So what are the weakness? Many patient, बहुत सारे patient उनको लगता है कि face to face हम डॉक्टर से नहीं मिले, या बहुत सी चीजें हमें demonstrate in person नहीं हो रही हैं. अपॉर्चुनिटी क्या है इसमें? प्राइवेसी एंड कंफर्ट की है, एंड कॉस्ट सेविंग है. पेशेंट को ट्रैवल करके जाना नहीं पड़ता. दे आर सिटिंग एट देयर होम, इवन फ्रॉम द डिस्टेंट प्लेसेस, फ्रॉम द डिफरेंट सिटीज. दे इवन कंसल्ट अस बाय द टेलीकम्युनिकेशन एंड get the proper advices. Many times they say that the patients have a fear in their mind that we may be misdiagnosed or missed opportunity may be there. So what are the applicability? Assessment confirm the diagnosis, contraceptive need, counseling, video conferencing or the Zoom conferencing should be done. It's a very good method. Like अब हम लोग virtual platform पे discuss कर रहे हैं, interact कर रहे हैं, and getting all the information involving all the fraternity throughout the countries. We and Agra persons, we are there, and from head office Mumbai, Ajay ji is there. So this is a advantage of the Zoom platform. Follow-up is the hybrid service can be, and in the patient we can advise the 1 visit, or an MMA 3 visits can be advised. So what are the key messages? Realize the need of PAFP, bring the couple on board and strive for 100% coverage. It capitalize on the basket and applicability on PA period, technology as far as possible, scope for entry in CAC services, concern policy, malpractice, and service cost and access are our concern. So adolescent RH need both online and offline services. This is very important. As already has been told to you, you have done your registration and pre-test. Now post-test is there, and your feedback that you have to give. And please don't click on the leave button. You just click to continue, and there will be post-test questionnaire, and you have to answer them, and then you will get a certificate from RAC for the trainer. Thank you. Thank you. In India, abortion is legal. Let us make it safe and respectful, and Samarth, sustain, accelerate mainstream access to reproductive health throughout health system. This is by the FOXI and the WHO and the Joint Effect FOXI for All, DHERA. Thank you so much for patient hearing and attending the session. I stop sharing. Yes.
There was some problem in joining. Only 100 participants were allowed to join. So many of our members of our society couldn't join.
Okay.
Shriman, please. What to do now?
This is a post-test link which is being shared by Meeting Events in the chat box. So participants, please click that link and do the post-test question, and then submit, and then you will get a certificate.
Any questions then can be asked now?
Yeah.
Savita ji.
Yes.
Sangeeta here.
Yeah.
Just elaborate RMP opinion, because I could join late. RMP opinion up to 20 weeks and RMP opinion up to 24.
Up to 20 weeks only one RMP opinion is required. Yes, if it is between 20 to 24.
Performers up to 24 weeks, 2 opinion are required,
Yes.
and 1 can perform or 2 are required to perform.
Only 1 is required to perform, but there should be opinion of 2 RMPs at least between 20 to 24 weeks, and there is a different form for those. Form E is there for 20 to 24 weeks, and Form D above the 24 weeks. 2 more forms have been added to this MTP. Yes.
D and E. Okay.
D and E.
Dr. Savita,
Pardon?
Make it available, Savita ji.
Okay, I will send on the main AOGS group. I will share.
Dr. Savita, may I leave? I have to join the other.
Yeah. Thank you so much,
Thank
Dr.
you so
Kanchan,
much.
for
Thank you
your
so much.
precious
Thank you, Sandhya
time.
ji
Okay,
is there, Dr. Sandhya. Thank you, and thank you all the participants. Thank you, Ajay ji.
अपने को unmute करो, Nidhi. You want to tell something?
Minor girl less than 18 years already has taken pills and come to us just for checking ki is it complete abortion, or if there is something products retained.
Even then you have to inform the police, because it comes under the you have to always, it's our duty, because some lady doctor in Maharashtra did the case on this minor. She was less than 18 years. She didn't inform the police. She did take the consent of her parents only, and she was put beside the bar.
Ma'am, only just for prescribing the medicine also we have to inform the
Yeah,
police.
this also comes under the MTP Act.
Ma'am, only informing or taking their permission?
You have to just inform it, then your duty is over.
Achha, what is this SAVER saver? How can our students get the certificate from there?
Those who are attending the meeting, then only they will get the certificate. If they are not
No, I am asking about saver, SAVER.
Saver is also the part of this safe abortion evaluation, values and rights and.
There are some our students who are doing DGO. From Narchi, from Narchi they are doing non-DGO.
Then
can they?
Yes, because if the one person is working with some hospital of gynae for 1 year, she can also perform the MTPs. She is also eligible. So they are.
But student, that means I am the fellow guide of Narchi, non-DGO. Then my students can get this certificate. They can become RMP.
I think they would have done the house job in Ops Gynae. They have done house job. They are non-DGO they are doing, but house job they have already done. Is it not? Is it not?
After MBBS, they can do non-DGO.
Directly.
Yes, directly. This is 2-year course. No, they are already doing under me, and I am qualified MS. Then I think they can also get the certificate.
Yeah, they can get. Yes, yes.
They don't need to do work in district hospital or somewhere else.
If they are working with you and you are qualified, you have your this place is has been registered for MTP, and yes, and you yourself has been registered, then they are eligible.
That means they should send their qualification to the CMO office, and then they can be registered. I will have to verify. I will have to give the certificate that they are doing under me.
Yeah, they have to. You have to certify.
They can be certified.
Yeah.
Okay, they can get the certificate of RMP, na?
Yes.
Savita ji, if they have done 6 months house job, then only after that they can be level as RMP.
ऐसा नहीं कि up to 12, मतलब these.
In the slide there was written if they are doing work for even for 6 months or 1 year, they can get the certificate.
अभी आरती जी ने आपको बताए थे ना कि कितने साइज तक के लिए कौन कर सकता है ना? तो
उसमें यही लिखा था.
Yes, 12 weeks तक तो these what people can do. 9 weeks तक तो खाली वो कर 9 weeks medical method abortion. Those who have assisted MTPs, 25 MTPs and done 5 MTPs independently can go for the medical method of abortion. Pardon?
They all are doing under my guidance, na?
Yeah.
If they are my students.
But if the size is bigger, more than 12 weeks, then one has to be either MD or DGO or work for 1 year in a gynae department. 12 weeks तो बहुत सारे लोग कर सकते हैं. और अभी कैटेगरीज तो बढ़ गई है ना उसके लिए. 3 months if one has done work in 3 months in a hospital under gynae, then she can also go for the medical method of abortion. Or 25 has assisted 25 MTPs and done 5 independently, then she can go for the medical method of abortion. अभी कोई और भी है? कुछ हो गया ना? Now should we close the meeting? अभी आप लोगों को छोड़ना नहीं है. You have to give click on the continue form. And
ma'am, already in the chat box I kept one link, ma'am, for
in
postage.
Chat box there is one link.